Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Kevin Wong, an anesthesiologist practicing in Saskatoon, Canada, and Kent Earle, a physiotherapist also practicing in Saskatoon, Canada, discuss pain reprocessing therapy and its use in treating chronic pain. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
All right, thank you all for joining us here today. My name is Kevin Wong, and I'm an anesthesiologist here at the University of Saskatchewan, and I'm excited to be talking to you all about pain reprocessing therapy. I will be doing the first part of this talk, and then my friend Kent Earle, who is a physiotherapist here in Saskatoon at Venture Rehab, will be doing the second part. Kent sees a wide range of clinical populations, including chronic pain, musculoskeletal injuries, and performance enhancement. I'm sure a lot of you that know me are wondering why I am giving a talk on chronic pain, because obviously I am not a chronic pain physician. This all happened kind of randomly in November of 2023 while I was watching TV. I was watching the Today Show, and there was a 5-minute story about Greg Whistler, who was going through his journey through back pain. He had 25 years of pain and had tried everything. Physiotherapy, acupuncture, massage, chiropractic work, medications, and he had a referral for surgery, and they told him that they could possibly make him better. He was wary of surgery, and he had the opportunity to be enrolled in a pain reprocessing therapy study that had 8 sessions over 8 weeks. At the time of the story, it had been 5 years after his therapy, and he was now living a very active, fulfilling life and had lost 50 pounds. I found this to be fascinating, so my curiosity was activated. I myself have had decades of back pain, starting from an injury in my early 20s when I wrestled for the University of Saskatchewan. My back pain at times was very debilitating. It was normal for me to take 1 to 2 days off of work every year for back spasms. One Christmas 4 years ago, I spent 30 hours straight in my bathroom floor and couldn't really move. I truly believed that I had a bad back, and I just had to suffer through this once or twice a year for the rest of my life with the specter of surgery hanging over me. I really didn't want surgery. This is what made me interested in learning more about PRT. I ended up going and starting to read about PRT on the internet. I talked to some of my friends in chronic pain, like Dr. Ian Jorgensen here in Saskatoon and Dr. Tim Bolton in Regina. They both validated the fact that there was an increasing amount of work and research being done on psychological approaches to pain. I also talked to some of our residents about their experiences in the chronic pain rotation in Calgary, and they confirmed that managing chronic pain with psychological approaches are an important part of every treatment plan. From what I understood, the landscape was changing to less reliance on needle and pharmacologic-based approaches, so I signed up for a practitioner course in March of 2024. I enrolled in this pain reprocessing therapy course. One of the clinical instructors, Dr. Yoni Asher, was the lead researcher for the back pain study referenced in the Today Show story. The course included 10 hours of video lectures and 12 hours of live Zoom course learning over a 4-week time period. I think the cost was about $1,000 US. I learned a lot about this course, and it helped to heal my back largely. Ultimately, it made me really excited about what to me was an entirely different approach to pain. And as an anesthesiologist, I manage pain for a living. During the Zoom portion of the course, there was over 100 people talking from all over the world, interacting. We would break out into small group sessions of 6 to 8 people, and it was fun and exciting to interact with people from Germany, the Netherlands, and Australia. A lot of people were psychologists, but there were also many physicians, physiotherapists, nurses, and in the first session, what was really cool was I noticed there was a second person from Saskatoon, Saskatchewan, also taking the course. This happened to be Kent Earle, who will be presenting later. We were able to kind of chat on the side and exchange information. It worked out that Kent is married to Darcy Earle, who works in our Department of Anesthesia as a provincial research facilitator. What a small world. Kent and I both enjoyed the course very much, and we've been exchanging ideas and information ever since. It's been a great collaboration, and I'm glad that he's here with me today to present. So what is pain reprocessing therapy? It is a modality to help change how a patient thinks, behaves, and interacts with the neural signals that cause them pain. It's been shown to be efficacious on a wide variety of chronic pain syndromes. The approach often involves a clinician or practitioner guiding the patient through exercises and techniques over a period of 6 to 8 sessions. One mental model I like to use to help describe PRT is that our brain is constantly being bombarded with signals. If I was to ask you right now to wiggle your toes and feel the socks on your feet, and then stop wiggling your toes, you can still feel the sensation of your socks. But 20 seconds ago, before I asked that question, your brain was filtering all that information out. It was not bringing it up to the conscious level. At all times, every part of your body is constantly sending signals and sensory information to your brain. Your brain interprets these as non-threatening or unimportant pieces of information, so you don't notice it. When we have chronic pain, our brain is sensitized to signals coming from the parts of our body that have previously been injured and interprets the signals from the part of the body as pain. For patients that suffer from types of pain that can be treated with pain reprocessing therapy, the pain isn't all in their heads. The pain is real. In this framework, though, the pain is all in their brain because it is how the brain is interacting with the signals sent to it. With pain reprocessing therapy, the goal is to try to modify the brain's ability to recognize signals coming from places in the body that have been injured in the past and correctly interpret them as normal signals. Let's look at the definition of chronic pain from the ICD-11, or International Classification of Disease, from 2022. Chronic primary pain, also known as neuroplastic pain, nociplastic pain, functional or idiopathic pain, is when pain has persisted for more than 3 months and is associated with significant emotional distress and or functional disability, and the pain is not better accounted for by another condition. Chronic secondary pain, sometimes referred to as nociceptive or neuropathic, is when the pain is a symptom of an underlying disease, such as chronic cancer-related pain, chronic neuropathic pain, or chronic secondary visceral pain. With chronic primary pain, the pain itself is the problem, and we cannot pinpoint a clear cause in the body. The majority of chronic pain is primary pain. The pain has taken on a life of its own. Chronic secondary pain is secondary to some disease process, like diabetes or a tumor. This paper, published in 2022 in JAMA Psychiatry, compares the effect of pain reprocessing therapy with placebo in usual care for patients with chronic back pain. The authors, Yoni Asher, Alan Gordon, and Howard Schubiner, were involved in the course that I took. This was out of the University of Colorado. It looked at 151 people with back pain randomized to one of 3 groups. They were getting 8 sessions of PRT over 4 to 8 weeks, or getting a placebo injection, or getting usual care, which was their usual physiotherapy and chiropractic work. In the they were followed for 1 year. In the PRT group, after 1 year, 33 out of 50 patients were pain-free or nearly pain-free at that point. Their pain score had dropped from 4 down to 1.18. For the placebo group and usual care group, there was 10 and 5 patients that were pain-free or nearly pain-free, and their average pain score had dropped from 4 down to 3. Here's another study, not specifically on PRT, but a different psychological approach to chronic pain, published by a group out of Harvard in 2021 in the Journal of Pain Reports. The therapy here was psychophysiologic symptom relief therapy, or PSRT. In this study, a control trial compared PSRT with usual care and a third active comparator arm, which was mindfulness-based stress reduction. The people who received PSRT has a statistically significant reduction in pain, 63.6% of people were pain-free after 26 weeks, compared to 25% of the people in the mindfulness-based stress reduction group and 16.7% of the people in the usual care group. Pain reprocessing therapy challenges our paradigm of pain. Pain is an important part of our lives. Our ability to feel pain is actually a good thing, as it helps us navigate through our environment. Pain is a danger signal. It keeps us from hurting ourselves, and although pain feels like it is produced in the body, all pain is processed in the brain. Chronic primary pain, or neuroplastic pain, is when the brain misinterprets safe and normal signals from the body and interprets them as danger signals that demand our attention. If we understand pain, we can figure out how to reattribute our signals. We can modify and even get rid of many types of chronic pain. Like I said previously, acute pain is absolutely necessary to help us navigate our environment, but chronic pain is often maladaptive and really affects our quality of life. With PRT, we work to challenge a paradigm that pain can only be managed and supported and decreased with pills and interventions. We introduce and support the belief that pain can be unlearned and we can rewire our brains. This paper, published in 2015 in Spine, is a systematic literature review of imaging features of spinal degeneration in asymptomatic patients. This meta-analysis reveals that imaging findings of spine degeneration are present in high proportions of asymptomatic individuals, and these findings increase with age. The conclusion was many degenerative features are likely part of the normal aging process and unassociated with pain. As you can see from Table 2, among 40-year-old asymptomatic patients, 68% will exhibit disc degeneration and 50% will have disc bulges. In 60-year-old patients, this increases to 88% for disc degeneration and 69% for disc bulges. So many patients and people I know with back pain point to their disc degeneration or disc bulge as the main culprit to their pain. I think it's really interesting to know that almost everyone has these changes, whether they have pain or not. This is an interesting study published in Spine in 2006. Are structural abnormalities on magnetic resonance imaging a contraindication to the successful conservative treatment of chronic nonspecific low back pain? In this study, they took MRI sequences of 48 people with nonspecific low back pain and then gave them a 3-month program of exercise therapy. After the 3 months, they took more scans, and then they also took more scans at 12 months. 89% of patients had severe degeneration, and 74% had disc bulges. What was interesting was that the severity of the MRI had only minimal association with symptoms. Some people had terrible pain with minimal MRI findings, and other people had improvement in their pain with significant MRI findings that remained even after they got better. And this is probably the most fascinating study that we went over, and this study was in the neurology journal Brain, and it was published in 2013. It's called Shapeshifting Pain, Chronification of Back Pain Shifts Brain Representation from Nociceptive to Emotional Circuits. This group was out of Northwestern University in Chicago, and they looked at a group of people who had recently injured their backs. The injury was within 12 weeks prior to their initial scans. These people were in pain, and their functional MRIs showed activity in their anterior cingulate cortex, thalamus, and insula. These are areas that you expect pain to be processed in the brain. About half the participants developed chronic pain just over a year later. They had repeat scans at 67 weeks, and the pain was associated with a different set of regions. These regions were the medial prefrontal cortex and amygdala. Here, you can look at some of the functional MRI images on the left that showed where the pain was initially at 12 weeks, and then where the pain lit up the functional MRI at 67 weeks on the right. These are completely different regions. These regions, the amygdala and medial prefrontal cortex of the brain, are not classical pain processing regions. Rather, they are responsible for learning, meaning-making, and emotions, specifically fear. The authors noted that pain reprocessing had shifted from the traditional areas to these new areas when the pain had become chronic. This supports the idea that pain can be learned, a learned response, even after the body is healed. The brain learned the pain. To highlight an example of how a brain quickly takes sensory information and learns and processes it in the future, I'd like to use this example. I'm going to show you an image right away. We're going to look at it for 5 to 10 seconds, and I'd like you to try to figure out what this image might be. Please don't say it out loud. What do you think you see? For those of you who saw the bee, good job. The brain is really good at learning and interpreting sensory information and giving its best prediction. I can show you this black and white image weeks later, and your brain will immediately see the bee. Your brain has learned a shortcut to the sensory information and doesn't go through all the processing because it has learned from the past. With pain, sometimes shortcuts develop, and the brain inaccurately attributes similar sensory signals from an area of the body that has been injured, and it recognizes as pain. I took this example from a talk that Dr. Yoni Asher did on YouTube on pain reprocessing therapy. He does a much more detailed and elegant explanation, but that's the gist of it. This slide goes over different criteria that help a pain reprocessing therapy practitioner recognize if there is a component of neuroplastic or primary pain that may benefit from PRT. Not all the criteria have to be there for every patient, but the more pertinent positives, the more likely the pain is neuroplastic. These are some of the questions we ask. Did the pain originate during a stressful time? Is there a history of multiple symptoms? Are the symptoms triggered or aggravated by stress? Are there triggers that have nothing to do with the body, like time of day or worsening symptoms at work? It gives a person the opportunity to prove to themselves that there's a component of their pain that is not structural and can be modified. It works by reducing their harm beliefs and activity avoidance. There are techniques and exercises that a person works on to help them change those maladaptive signals and reattribute them to being non-threatening sensory signals. The brain is plastic, and over time, this leads to decreased pain and sometimes extinguishing of the pain entirely. Finally, there is some recognition and discussion around the emotional component of pain and how your environment, emotions, and relationships can augment or decrease pain. As mentioned before, depending on the person, it can be done in as little as 3 to 4 sessions, but often takes 6 to 8 sessions to go through a course of treatment. For those of you who have found this interesting, if you want to learn more, I'm always happy to talk about this in person, but a great start is the book The Way Out by Alan Gordon. You can get it in the library or bookstore or online. It is a short and easy read, and it goes over the whole process of PRT. But I think there is a lot of benefit to one-on-one guidance. That's where I'm going to hand this over to Kent, who is a practitioner that uses this essentially every day in his practice at Venture Rehab. There are several practitioners that also are doing this at Venture Rehab, and I hope many more in our province will learn about this and take the provider course and incorporate it into their practice. Thank you very much.
Thank you, Dr. Wong, for the introduction and the first part of this presentation. I'm humbled and really grateful to be asked to present to you all this morning about integrating pain reprocessing therapy and the new neuroscience of pain into practice. I'm a physical therapist, as Dr. Wong said, at Venture Rehab Sciences Group in Saskatoon, and was originally trained primarily in musculoskeletal injuries and graduated from the University of Saskatchewan. However, after about 15 years of practice, I kept running up against a very large population of my patients with chronic symptoms who I simply could not get better. I'm sure that many of you can relate as well. We have such great tools for dealing with acute problems, but they're largely ineffective with chronic symptoms. Worse still, I was often at a loss to explain to myself or these patients why they continue to experience pain. Their tests were often normal or insignificant, and their pain was out of proportion to their physical findings. They didn't respond as expected to treatments that should help physical pain, be it manual therapy, exercises, injections, or surgery. They'd sometimes get relief, only to have it return later. They'd have seen many different physicians and practitioners and have tried many different treatments with mixed results, but no lasting benefit. They were frustrated, and ultimately I was frustrated too. These types of patients can fall under a broad category of medically unexplained symptoms, where the objective findings simply don't match the subjective symptoms and disability. And this is not a small number of people. In this systematic review, the range was 40 to 49% in primary care. What we're now learning, though, is that many of these medically unexplained symptoms are now understandable through recognizing the new neuroscience of pain, as Dr. Wong described. This insight really was very startling for me. And I initially went through a bit of an existential crisis about what to do and how to change how I approached these cases. Gradually, though, this new understanding of pain neuroscience, I began to screen my existing patients and new patients for neuroplastic symptoms and began to think of their pain mechanism or pain diagnosis rather than the pathoanatomical or biomechanical diagnosis alone. What I was shocked to find was how prevalent neuroplastic symptoms are. And I began to introduce this information to patients and explain how our nervous system changes with chronic pain. Happily, I found that many patients were surprisingly receptive to this information and acknowledged how much sense this made to them. So I began to combine pain reprocessing techniques with manual therapy and exercises, or simply provided the neuroscience education and pain reprocessing strategies on their own. And as I started to see patients improve and recover, my satisfaction and passion for my work immensely increased. In preparation for this presentation, I went back through my files over the last year, and I've seen over 150 patients who met the criteria for neuroplastic pain. Now, not everyone is open and accepting to this diagnosis, or ready and open for pain reprocessing. However, in my chart review, over 50% of patients that I worked with had improvement of their pain and function with these strategies. Although it's difficult to determine for certain, I'd estimate that roughly less than 10% of these patients would have improved with usual care alone otherwise. Even several of my long-standing patients who I'd seen for many years had remarkable improvement and recovery, some to the point of being completely pain-free after years of only being able to manage their pain. So this is a case history illustrating a typical average patient who I've seen. This individual is a healthcare worker with chronic low back pain for more than 10 years. The pain started after a relatively benign event while getting dressed and experiencing back and leg pain. There was a significant stress around the time of onset of symptoms, with a close family member going through cancer treatment. This patient was able to receive an early MRI, which showed an L4-5 disc herniation and nerve root compression. Given the findings and the severity of symptoms, and microdiscectomy was performed, which improved their leg pain, but the back pain persisted, which is very common after back surgery. Now, this individual attended postoperative physiotherapy, but unfortunately was not able to return back to their pre-injury work and was accommodated in a new and more sedentary position. Several years later, they had a recurrence of radicular pain without a clear causative event. A new MRI was ordered, which showed another disc herniation, but this time without nerve compromise. Neurosurgical consult and a second opinion both recommended against surgical management, as the clinical findings, symptoms, and imaging results did not correlate. An epidural steroid injection was performed, which offered only partial benefit. They also did a selective nerve root injection, which was not helpful. And when I saw this individual, their pain was 7 out of 10 at worst, 2 out of 10 at best, and 4 out of 10 on average. I went through the diagnostic criteria of neuroplastic pain, and they had many neuroplastic features. The pain had been going on much longer than expected, and there had been a recurrence without a clear mechanism of injury. There was a stressor around the time of onset. Both the back and leg pain were inconsistent. The pain ranged in intensity, was worse after activity than during, and presented in different areas of the back and leg. Stress made their pain worse. There was also a history of adverse childhood experiences. Also in their clinical testing, there was inconsistencies and discrepancies between heel and toe walking and key muscle testing. All other neurological tests were normal, despite their neuropathic symptoms. Spinal mobility was also within normal limits. This individual was open to the understanding of neuroplastic pain, and I saw them for 6 sessions over 8 weeks, with the initial focus on pain education and developing a good understanding of neuroplastic pain, reframing it as due to neuroplastic changes and not ongoing damage in the body. We focused on safety messages and re-engaging in avoided movements and activities. I also helped them in recognizing the triggers of their pain related to psychosocial and emotional stressors. Remarkably, after 8 weeks, their pain reduced to 1 out of 10 most of the time, with rare increases to 2 to 3. This individual was able to return to their physician and began to wean medications while continuing the pain reprocessing strategies on their own.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.